Hello, everyone. Nice to meet you again. I would like to start today's session, 2022 lecture series for first semester lecture series. And on behalf of Professor Dong-Soo Lee, I'd like to introduce our lecturer, Dr. Hyun-Jong Lee. Dr. Lee is currently in the Department of Nuclear Medicine in Samsung Medical Center. And Dr. Lee has accumulated outstanding achievements in the research of oncology nuclear medicine. So today, Dr. Lee will deliver us a lecture regarding nuclear medicine imaging, image reading, and clinical perspective, which will discuss about practical issues in image reading, and particularly the reporting of the our nuclear medicine images. So please welcome Dr. Hyun-Jong Lee.
Thank you for your kind introduction. Can you hear me?
Yes, we can.
Thank you. I am Hyun-Jong Lee, and please wait just a second. I think you can see this slide, right?
Yes.
Thank you. I'm Hyun-Jong Lee in Department of Nuclear Medicine of Samsung Medical Center. The topic of this session is nuclear medicine image reading in clinical perspective. I informed you the topic as nuclear medicine image reading and the therapy in clinical perspective first, but I deleted the therapy part because I have not enough therapy experience yet, and it was difficult to find appropriate therapy case in my viewpoint and even in this institute, because my institute have just started therapy 6 months ago, so there is a few cases. So I would like to only talk about nuclear medicine reading in this session. Do you know this game? Yes, Sonic 3 and Knuckles. Have you ever played this game? I have been playing this game over about 20 years. It is still an exciting game for me. Do you know this game? Yes, it is Peggle. I think you may be unfamiliar with this game. The aim of this game is to touch all red blocks within 10 balls. So it is a little bit similar with a pinball game. Have you ever played this game? I have been playing it over about 10 years. It is still an exciting game for me. And do you know this game? Yes, it is Pokemon Star. I think you may be very familiar with this game. I love this game, so I remembered all the monsters once upon a time. Have you ever played this game? I have been playing it over about 15 years. It is still exciting. Why did I introduce you these games? I played those games not only in my medical school days, but also in my resident doctor days. Even in days, I played these games, especially in some lectures or conferences. I did not listen lectures. Do you listen lectures? I did not listen lectures. Why? because it was boring and it was monotonous, and they don't give me any motivation, and there was no profit to listen, and there was no reason to listen. So I did not listen lectures, and I only played these games. Not in all lectures, but in some lectures, which was boring, monotonous, etc. I want your interest despite of online lecture. I think the lecturer has a responsibility to make audiences listen. So I should make you listen this. So I promise to you and myself. So I try to make this session at least not so boring and interesting. And I'll try to give you even a little bit of motivation, and I'll give you a little bit of profit. And I expect that there is at least one reason to listen this session. Can you imagine what I'll talk about? What is clinical perspective? What is clinical? What is clinic? You may think that I imply nuclear medicine physicians are not clinicians. I absolutely do not think so. I absolutely think nuclear medicine physicians are also clinicians. However, many nuclear medicine physicians seem not to be clinicians. Some of them seem not to have any interest in patients themselves. I suggest some unique viewpoints in nuclear medicine reading. In this session, I will not teach you special things. Maybe I have not enough experience to teach you something. I just want to communicate with you about this topic because we often forgot this point. So I want, although it is very difficult, but I want you to participate in this session anytime. So you can talk about anything in any time. I want your interest desperately. I want to highlight this comment. If you are a nuclear medicine physician, I have heard that most of you are nuclear medicine physicians. So please think about this. Medicine is an art, not a science. If you are a nuclear scientist, please think about this. Science is not for nature, but for a human. So medicine is an art for a human. It is not the absolute science. Please remind this point. This session is composed of two contents. The first is communicating by nuclear medicine reports, and the second point is considerations in nuclear medicine imaging reading. Let's talk about this topic. I think it is the topic which should be taught to nuclear medicine or radiology resident doctors foremost. This is the most important thing, I think. However, I have not ever heard about this topic from professors or fellow doctors in my resident course. Have you ever heard about this topic? If you have heard about this, your institute has very, very good environment, and maybe your professor, your senior professor have a very, very good experience and teaching skill. What is a report? It is the most representative communication tool of nuclear medicine physician. It is for other physicians, not only for other physicians, but also for patients. We cannot always send an email or call a phone to report and discuss image findings of nuclear medicine images. Probably a report may be the only communication tool of nuclear medicine physicians. Have you ever thought the importance of report over? I referred this article to prepare this session, how to create a great radiology report in Radiographics journal. This is related to a radiology report, but there is no difference between radiology report and the nuclear medicine report. So I want to discuss about this point. Most of the reports are composed of two parts, findings and impression or conclusion. So firstly, let us think about key principles for the findings. First, provide information briefly and clearly. Second, use terms of perception sparingly. Third, avoid redundancy. And the last, keep it organized. So first point is a brief and clear information. Maybe you think like this, and even I think so. No, I thought so. I have thought so. Now I don't think so. Let's see. I want to describe all the information with my best efforts. All the information. And I want to make impression for all the findings with my best kindness. In these comments, the important point is with my best efforts and with my best kindness. And I want to convey information in one sentence for briefness and clearness. So you may think like this with your efforts and kindness and consideration. Let's see some examples. Please use short, informative phrases than clauses. Let's read this. There is a 2.5 centimeter sized nodule with mild FDG uptake in the left upper lobe of lung, which newly appears compared to the previously study indicating possibility of malignancy. It is too long and it is difficult to understand. Of course, it is easy to understand for us, but it is a little bit time consuming to read and understand this sentence for clinicians. So it can be refined into a new 2.5 centimeter size nodule with mild FDG uptake in the lung LUL. The word new is very effective in this case. However, there may be some differences between languages. In your country, I'm very curious about which language is used for report. I expect you can answer for this question with your voice, or you can write your answer in chatting sheet. So I am very curious about it. In my institute, for example, in my institute, findings are written mainly by Korean, and conclusions are written by English. I remember when in my resident period, I was in a Seoul National University Hospital, and in that institute, findings also were written by English, but in this institute, findings are written mainly by Korean. But conclusions and impression are written by English in most of the Korean institute. How about you? It is a little bit awkward to write only phrases in Korean. is a little bit awkward grammatically. So clauses are used to write findings. Anyway, if your language permits phrases, please use them. Short, informative phrases. Let's see one more example. There is a heterogeneous attenuation and small nodular lesions with faint FDG uptake in the peritoneal cavity, which increases in extent compared to the previous study, indicating aggravation of peritoneal seeding. Even for me, it is very difficult to understand and even read this. So it can be refined into increase in extent of omental haziness with faint uptake. The radiologic term, omental haziness, is very effective in this case. Please use short, informative phrases. Another point is describing incidental findings clearly. Do not describe incidental findings equivocally. There is a low attenuated lesion without demonstrable uptake in the right kidney upper pole without significant change compared to the previous study, which favors benign characteristics. This sentence includes all information, right? But it is not right. It is not clear. It is not brief. So this sentence can be refined into this phrase. Unchanged benign cyst in the right kidney, that's all. In this case, the word unchanged and benign are very effective. If possible, clear information as benign should be provided. Benign. Don't be afraid of describing or using the word benign, because because we are reading doctor. Let's write brief and clear report. Yeah. The second point is avoiding terms of perception. Maybe you think like this, as follows. Even I think so. Oh no, I have thought so, but now I don't think so. I just saw that there was something like a nodular lesion in the lung. I just saw. I just saw. Frankly speaking, I do not want to or cannot say there is definitely a nodule in the lung. I just saw. So I cannot say there was or there is a nodule in the lung. Frankly speaking, I just described that my perception reported to my brain. I cannot guarantee the presence of a nodule. I have no responsibility of the presence of a nodule. I just saw that finding. Now, if you think like this, please waste this mind. And I will waste this mind together. And moreover, you may think like this. I just saw there was something like a nodular region in the lung. I am not sure that was a nodule, but I saw that there was something like a just nodule. It is a very awkward and equivocal mind. More frankly speaking, I do not want to have any responsibility when it is proven that there is no nodule in the lung. I just saw something like a nodular thing. I didn't write there was definitely a nodule. So some radiologists or nuclear medicine physicians want to shout like this. I just said what I saw. I just said what it seemed. Please waste this mind, and I will waste this mind together. Please avoid the excess use of terms of perception as the following. Let's see some examples. A nodule is seen. The consolidation is noted. A radio uptake is demonstrated, assisted, visualized. It seems like, it appears. In report, what I saw was what there was. Right? Do not avoid responsibility. I still have a lot of avoidance for responsibility, but let's waste it. However, there may be some differences between languages. In some languages, it may be hard to avoid the perception terms. There may be some differences. Nevertheless, I recommend the use of term about presence or absence. I expected that all languages have terms about presence or absence, right? So I recommend the use of terms there is or there is no. Third point is avoiding redundancy. I saw many reports with too many redundant expressions. A little bit effort can make reports with lesser redundancy. Maybe you think like this. I think it seems unnatural or even unfair that careful deliberation is distilled into a few short phrases. I read during about about 20 or 30 minutes in one case, but but I wrote a few short phrases. I cannot accept it. You may think like this. I'm worried that terse means short. Short reports are viewed as cursory, overconfident, or calvary means overly confident. So in resident periods, and even in my position, I still have some worry about this, but let's waste it. I think the longer report reflects my consumed time and the best efforts. But waste this mind. Please avoid redundant terms and radiology, nuclear medicine, neologisms. Neologisms means new or newly developed word, term. So let's see one case, one example. There is a redemonstration of the right to hepatitis of mass compared to the previous study dated August 4th, 2015. There has been an interval increase in size. It is not too bad sentence, but it can be refined into the following. Enlarged right hepatic lobe mass compared to blah blah. The word unchanged is so effective in this case. In Korea, I have seen many reports with no significant interval change, or no interval change. These phrases are widely used in Korea. I want to make it more briefly, so I used no change, no significant interval change, no interval change, or no significant change, or no change. But I found that the term unchanged is the most effective term. Yes, unchanged, the term unchanged includes all the meaning. And yes, please waste redundant terms. When you review your report, you may find easily so many redundant terms even in your language. The last point for finding party is keeping the report organized. Sorry. There is one more example, right? Yes. Again, noted are multiple peripherally enhancing complex peripancreatic collections with thickened and irregular words which have not changed in size or configuration since the prior exam. It is a very complicated sentence, so it can be it can be refined into unchanged complex peripancreatic collections. Right. The term unchanged in there is a term unchanged in this slide. So I explained about unchanged already. The last point for finding part is keeping the report organized. Let's see one bad report. I want to read this, but I'll skip it. Multiple long blah 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 blah. Can you understand this report? Yes, we can understand. We can understand it, but there it is it is too time consuming and too complicated to understand. So if we use numbered list, it is better to understand the findings like this. Long nodules compared to blah blah. Number 1, blah blah. Number 2, blah blah. Number 3, blah blah. So we can understand it more easily. We can, not only we, but also clinicians, but also patients. Let's wrap up key principles for the finding part. So provide information briefly and clearly, and use terms of perception sparingly, and avoid redundancy, and keep it organized. Those principles are all for physicians and patients. The reports are read by physicians and the patients. They are not stored in a closet in nuclear medicine reading room, right? Right. Please remind this. You are writing your report for other people, not for yourself. Yes, let's check time. I want to check. Okay. And most of reports are composed of two parts: findings and impression or conclusion. Second, let's think about key principles for the impression or conclusion section. Lead with the diagnosis, use appropriate lexicons, avoid technical language, and avoid words that carry therapeutic implications. First point is leading with the diagnosis. In impression or conclusion, the favored diagnosis should be suggested. If you cannot suggest favored diagnosis, you should suggest differential diagnosis. Of course, key findings supporting the diagnosis may be helpful in complex cases. What I think most important is an appropriate lexicon to express the likelihood of a diagnosis. Let's see about various lexicons. Which lexicons do you use? Lexicons mean the widely used or widely used terms. So one article suggested 5 lexicons according to the probability of diagnosis, consistent with probable, possible, less likely, and unlikely. It is very similar to lexicons which are used in my institute. I am very curious about which lexicons you use in your report. You can answer for my question in with your voice, or you can chat in the chatting sheet. In Thomas Jefferson University, survey was performed to find out that each term give how much probability of diagnosis to physicians. I have ever used terms which are highlighted with red box, consistent with, highly suggestive, most likely, compatible with. But I think diagnostic of and represents are very good terms because they clearly show the diagnosis without any uncertainty. Terms scored as terms indicating the highest probability should express no or any uncertainty. For high probability, suspicious, concerning, probably, likely, worrisome, suggestive, or suggested. In my institute, suspicious or worrisome, which are highlighted with the blue box, is used for lesser probability than the survey. These terms, suspicious and worrisome, are used in intermediate probability, I think, in this institute. Like this, lexicons are differently used in each institute. Therefore, it is needed to communicate to other physicians about these expressions to prevent misunderstanding. Probably and suggestive are widely used in Korea. How about your country or you? If you have not enough certainty, equivocal and possible can be used, and also may represent, can represent, questionable, or more questionable or uncertain. You can use those lexicons. For low probability, the term unlikely is the best choice, I think. Unlikely. It is a very easy term. Not included, which is highlighted with the blue box, seems to be used for a little bit higher probability than 10% or 25%, maybe about 30 to 40% in Korea. Or it is used to give cautions for possibility of malignancy. So I think I recommend the use of the term unlikely for to indicate a low or very low probability of certainty. In Harvard University, several terms were suggested with agreement among radiologists. Consistent with, highly suggestive of, may represent, unlikely, very unlikely, demonstrated good agreement in Harvard University radiologists. I think we can select appropriate lexicons from those examples. Use appropriate lexicons which are proper in English or your language. Use appropriate lexicons which are well accepted by clinicians in your institute. And the most important thing is that use appropriate lexicons always consistently. If you use two various lexicons, there may be miscommunication, so that reliability of a report will lower. Reliability is the key point of the report. Third point is avoiding technical language. The technical language is often at the forefront of the nuclear medicine physician's mind. So you may think like this, I want to share these interesting findings with all my clinician colleagues. But do you believe they are interested in detailed technical descriptions of nuclear medicine imaging? I don't think so. I'm not sure clinicians are interested in following terms. Honda sign, you know about Honda sign, which represents in, which can represent in insufficient fracture or compression fracture of sacrum in bone scan, hot kidney, and diaphragm attenuation artifact, which can represent in myocardial perfusion SPECT imaging. Probably even some clinicians are not interested in hypermetabolism. I think I'm sure clinicians are interested in following terms: benign, malignancy, metastasis, hypoperfusion, reversibility. They only they are only not only they are interested in those terms. So we just provide that information. If you want to provide the technical information, it will be helpful to some clinicians. So please use the findings section, not conclusion or impression section. The last point is avoiding therapeutic implication. In my resident periods, I wanted to suggest therapeutic implication because I believed it was clear reading. So partial metabolic response, stable disease, progressive disease, and complete metabolic response. Still, I use those terms. I want to make a therapeutic implication. However, my thought has been slightly changed. There are three reasons. The first point is clinicians expect response than progression. Second point is increase in FDG uptake does not always mean progression, as you know. And progression does not mean that the previously used therapeutics is inactive at all. In short, it is important to give some spaces to make decisions in clinical view. The nuclear medicine report is just a report. Other physicians also know about that, so it may be a little bit inappropriate that we strongly suggest or even argue the response of patients. There are other important issues, two other important issues. The first is the insurance issue. It may be a special issue for Korea. I want to introduce about this. In health insurance system of Korea, avoiding therapeutic implication is more important issue because in some cases, same chemotherapy regimen is prohibited to be used when radiology or nuclear medicine reports progression of disease, progressive metabolic disease. So health insurance system cannot understand why same drug should be used even in progressed stages. They cannot understand. In earlier part of this session, I pointed that the medicine is an art, not a science, but they cannot understand this. Unfortunately, government absolutely cannot understand this point. So although image findings indicate progression of disease, such as increase in size or increase in uptake or increase in extent, clinicians can say there is no progression, even though there is a progression sign in image. In aspect of patient's condition or patient's symptom or patient's social circumstance or health insurance issue. In addition, nowadays, immuno-oncologic treatment is widely applied in lung cancer or melanoma. After administration of immunotherapy, drugs such as pembrolizumab, there may be a pseudo-progression. So in recent days, there is a criteria for to diagnose pseudo-progression. Pseudo-progression is a phenomenon that size and uptake of lesion increases despite the presence of response for immuno-oncology therapy. Therefore, it is recommended to describe findings with increasing size and uptake itself, not to conclude as aggravation or progression in Korea or in my institute. Let's wrap up key principles for the impression part. Lead with the diagnosis. Use appropriate lexicons. Avoid technical language. Avoid words that carry therapeutic implications. Those principles are all for clinicians and patients. The reports are read by clinicians and patients. They are not stored in a closet in nuclear medicine reading room. Please remind this. You are writing your report for other people, not for yourself. Check the time and okay. So I recommend you to read this article, Reporting Guidance for Oncologic FDG PET Imaging in Journal of Nuclear Medicine. So this article is well described what we should report and how we should report for oncologic FDG PET imaging. There are essential elements of reporting. So you can find this article and please, I recommend you to read this article briefly, not detailedly. This was the first part, and I am trying to proceed this session at least not boring and interesting, and I want to give you a little bit of motivation, and I want to give you a little bit of profit, and I expect there is at least one reason to listen this session. Okay, the second part is are considerations in nuclear medicine imaging reading. What should we consider? What should we consider in nuclear medicine reading? I suggest these three groups: patients, clinicians. Clinicians means at first I said nuclear medicine physicians are also clinicians, and but in this context, clinicians means direct healthcare providers, not us. So patients, clinicians, and nuclear medicine physicians, ourselves, right? But should we consider three groups with the same positions? Same positions? No. How should we consider these three groups? First is patient. All reading is for patients first. Next are other physicians. I expressed them clinicians in this part, in this slide. The last positions are ourselves, nuclear medicine physicians. We should always think whether this conclusion is helpful for patients. The report is helpful, should be helpful for patients. What does it mean? What does it mean? I and you, we know the meaning of right. I searched the meaning of right in English dictionary. So there are three representative meanings of the term right. The first is correct, and the second is suitable or correct, or as it should be. And a third is considered fair or morally acceptable for most people. What is the most important meaning of right? What is the most important meaning of right? Does it mean correct? Yes, but I don't think so. It is not the most important thing. The most important meaning is morally acceptable or suitable. I think correctness is important. Correctness is important, right? But not the most important. Okay, so right to report means first, fair or acceptable or suitable report, and then it should be correct. All of you know about this table, about diagnostic performance. True positive and true negative are our goal, maybe our dream. They are our dream. However, there is no answer. We cannot always know the answer for patient's condition because we do not always perform biopsy or pathology confirmation for all lesions, and we cannot always find an absolute answer for them. Therefore, there must be false positive and negative. Do not be afraid of false positive and false negative. It is very natural. Furthermore, in nuclear medicine reading, there are many cases to make false positive or make false negative intentionally. Intentionally. I do not mean let's make a lie. Let's make a lie. I want to make a lie for this. No. I just suggest that we can tone up or tone down to provide better management for patients. It is all for patients, so it is a right report. So I said there are many cases to make a false positive or false negative intentionally, but that does not mean we can make a lie. So I want you to understand this point correctly. So let's see some cases. The first case, the three cases are related to toning up intentionally, and the other case is related to toning down intentionally. And the first case is a 55 years old female patient with ovarian cancer, and she had undertook hysterectomy and salpingo-oophorectomy and lymph node dissection and omentum resection following adjuvant chemotherapy. And there were inguinal lymph nodes with FDG uptake. In abdomen and pelvis CT, there were borderline lymph nodes in both inguinal areas. So radiologists said that they do not express, they do not give us any implication of these lymph nodes. They just described that there were borderline lymph nodes in both the inguinal areas. So FDG PET-CT was performed, and in FDG PET-CT there were lymph nodes with mild uptake in the bilateral inguinal areas. So we reported there are equivocal lymph nodes with both inguinal areas, and tissue confirmation was recommended. How do you think about this case? Some of you may think these lymph nodes may be just reactive lymph nodes. I think so. I think so, but we toned up this case intentionally because those inguinal lymph nodes were newly developed in abdomen and the pelvic CT, and there was FDG uptake, not too high, but a mild FDG uptake. There was FDG uptake, and inguinal lymph nodes are easy to approach for biopsy. So we turned up intentionally. My English is a little bit poor, so there may be some delay for my my comment. If someone asks me to bet your money whether these lesions are benign or malignant, I'll bet these lymph nodes are benign. I think so. But we reported equivocal lymph nodes in both inguinal areas because reasons that I mentioned earlier. So inguinal lymph nodes, pathology confirmation was performed, and there was no malignant tissue. Was this report correct? No, not correct. Not correct. False positive, right? Was this report inappropriate? According to some, according to each nuclear medicine physician or clinician, someone may say this report was inappropriate, and someone can say this report was appropriate. Was this report right? I think I think this report was right, not correct, but right. I want to emphasize this point. Not correct, but right. So write to your report right. Write to your report right. The second case is 68 years old male patient with LUL lung cancer. LUL lobectomy was performed, and there was LLL nodule, which was suspected as metastatic nodule. So radiotherapy was performed. And after radiotherapy, subcarinal lymph node was found in chest CT. In chest CT, there is a subcarinal nodule with oval shape, and with enhancement, as you can see. But there was no note and no description for this subcarinal lymph node in chest CT report. So they do not give us any information of impression for this subcarinal lymph node. But the key point is this lymph node is developed after radiotherapy with oval shaped, right? The FDG PET was performed. Subcarinal lymph node, there was a subcarinal lymph node with high uptake, and the size of this lymph node was increased. So we report that there is it is suggestive of metastatic lymph node. How do you think about this case? It is metastatic. Is it a metastatic lymph node, or is it a reactive lymph node? It is very difficult to discriminate malignancy or benign in this case. In aspect of the shape of this lymph node, oval shaped, we can it favors benign lymph node, and after radiotherapy, this in terms that this lymph node is developed after radiotherapy, so it is this lymph node may be a reactive lymph node related to radiotherapy. But there is too high uptake, and it is and the size of lymph node is increasing. In those aspects, it favors metastatic lymph node. So it is a very equivocal finding. I said equivocal finding, but we turned up intentionally, suggestive of metastatic lymph node, because subcarinary lymph node can be relatively easily approached for biopsy with bronchoscopy, and in lung cancer patient, if this lymph node is metastatic lymph node, it is a solitary metastatic region. So there may be more treatment options for this lesion. So we turned up intentionally. We think equivocal, we don't know, but we turned up intentionally. So the pathological confirmation was performed for this subcarinary lymph node. Clinicians said sarcoidosis reaction is possible. They said before the pathology confirmation. So they thought about the possibility of a reactive lymph node. So they said biopsy is needed. So I forgot to describe the pathology result of this finding, but the important thing is that was this report correct? No. And was this report inappropriate? I don't think so. Was this report right? Yes. Even if this report was not correct, this report was right. What I want to highlight is this point. I expect you can easily understand my viewpoint. Third case. Let's check time. Sorry, I can check the time. Okay, and the third case is 72 years old male patient with supraglottic cancer. Definitive CCRT was performed, and there was a residual lesion. So partial laryngectomy with lymph node dissection was performed, and there was and cricoid cartilage lesion was found in FDG PET-CT, follow-up FDG PET-CT. There was uptake in the cricoid in the posterior aspect of in the anterior aspect of cricoid cartilage. So we reported that there is a possible recurrent tumor in the cricoid area. So further evaluation was recommended. Intentionally, this site, the focal uptake in this site is often visualized, is often found because of physiological uptake of vocal cord or inflammatory change of piriform sinus, but we turned up one step intentionally, not equivocal, but possible. Right? Recurrent tumor in the cricoid area, because this site is easily approached by endoscopy, and this site is very near to the previous tumor site. So we turned up intentionally. Abnormality in examination with endoscopy. Was this report correct? No, not correct. It was that this report was incorrect. So we reported the false positive, right? Was the report inappropriate? Was this report right? Yes, this report was right. Not correct, but right. The last case is related to toning down intentionally. 69 years old male patient with alveolar lung cancer with right adrenal metastasis. Chemotherapy was performed, and palliative radiochemotherapy was performed. And palliative chemotherapy was performed consecutively, and palliative pembrolizumab was administered. But right adrenal lesion was, but there was a suspicious lesion in the right adrenal gland. Clinicians have a plan to proceed additional radiotherapy if there was no other metastatic lesion except right adrenal lesion. That clinical circumstance is most important in this case, as you easily understand. You can easily understand. So there was a hypometabolic lesion in the right adrenal gland, so we can report definitely there is a right adrenal metastasis, right? But we found a focal hypometabolic lymph node in the superior mesenteric artery root. Very equivocal and very annoying finding. So, but we reported there is a probable reactive lymph node in SMA root area. There is no answer for this. Is it possible to obtain the pathologic tissue of this from this SMA root lymph node? It is very, very difficult, and there is no need to obtain the tissue from this finding. So even if it may be a metastatic lymph node, we cannot say strongly that it is a metastatic lymph node. And the clinicians want to perform additional radiotherapy. And one more thing is it is not usual that there is a solitary lymph node metastasis in the SMA root area. So I thought this finding is somewhat equivocal, 50%, something like this. But I toned down intentionally. Probable reactive lymph node. I reported in side of benign lesion. Right adrenal recur. For right adrenal recurrence, of course, there is no pathology result for SMA lymph node. And it is impossible to obtain this tissue. So clinicians proceeded additional radiotherapy for local recurrence as they wanted. Was this report to make false narrative intentionally for clinicians? No. I just toned down intentionally. I did not make any lie. I just toned down the findings intentionally for patients and for clinicians. So was this report correct? No, I'm not sure. But this report was right. So do not use it too frequently. And be frank if you are not sure. And provide spaces for clinicians. Let's see some cases, N1 or 2, or N2 or 3 stages in lung cancer. For these cases, clinicians want to make a therapeutic option for their mind. So we can use equivocal the term equivocal for metastatic lymph nodes in lung cancer. And in case of overall partial metabolic response, but some lesions show increased size and uptake, we can provide spaces for clinicians to make a decision for stable disease, and leave uninterested findings as they are. It is difficult to discriminate pleural or chest wall lesion in extensive lung cancer, but do not hesitate to describe it because clinicians are not interested whether it is a pleural lesion or a chest wall lesion in extensive lung cancer. And in extensive ovarian cancer, mesenteric lymph node or seeding lesion cannot be discriminated well, but do not be afraid of discriminating those lesions. So let's wrap up this session. Write your report briefly and clearly, and use your lexicon consistently. Tone up or down intentionally and thoughtfully. First for patients, and second for other physicians. 네, 감사합니다. Thank you for listening, and please give me some questions or comments.
Thank you for the lecture. And would there be any questions or comments? And I think it was very useful lecture. So before others, I'd like to ask about the lexicons actually. So do you think our clinicians also have consensus with us about the lexicons? So the clinicians who order this like PET-CT, do they also have similar consensus with us about the probability of the lexicon that we use?
So your question is about whether clinicians have a consensus for lexicons which we use?
Yes.
That's a very good question. Frankly speaking, I don't think so. They are not sensitive for the probability of diagnosis. So I don't think they have any difference certainty between probable or possible, something like this. So yes, I don't think they have. There is no consensus among clinicians.
So actually, what I think, is it like right to it is important to consistently or appropriately use the lexicons, but I rather think it might be more important to make a consensus with that specific clinicians to know their intention actually, because I'm not sure how they will understand my interpretation, and that kind of things are somewhat curious. So
yes,
I think
actually it is the best scenario that in multidisciplinary conference we can communicate about lexicons at first, and we can use the lexicons about the probability after, but in actual clinical field, there is no opportunity. And as you mentioned, they cannot understand deep, our deep 어떤 I cannot bring the appropriate English word, but yeah, our deep mind. So yes, that is one problem.
Thank you. And regarding the case number 4, maybe whether I get the point about your intention, but I'm not sure. Wouldn't it just for would it happen like if you can like rather recommend close follow-up to give some attention for the clinician? What would happen like that could also be a other choice. So give it like interpretation as equivocal and make clinician for just close follow-up can be what I think can be some other consideration. But how about your?
Frankly speaking, I agree with you, but because there is no difference whether we report that lesion was equivocal or that lesion were reactive lymph node. Maybe clinicians would perform therapeutic option which they wanted, but yes, in this case, I said I reported a little bit aggressively, as you mentioned. So that's yes. I frankly speaking, I agree with you.
For the comment, and I think people need to think carefully. I get the point. Thank you for the lecture, and I think there is some question in the chat.
I am also checking. Thank you very much for wonderful solving most of query. Can you please elaborate when you see or suspect pseudoproliferation, how to communicate to doctor, and should we? Yes. So we can report the case of pseudoprogression like this. There are some lymph nodes which showed increase in uptake or increase in size in, for example, subcarinal or right hilar areas. But it seems a but there is a possibility with pseudoprogression. So clinical correlation is recommended because we cannot catch patient's actual condition and the patient's actual circumstances. So we cannot make sure the possibility of pseudoprogression. So because there is no, but I have not ever seen about the radiological differences of radiological finding between pseudoprogression and real progression after immuno-oncology treatment was not clear. So are not clear. So let me check some more details about that.
Actually, what I have from the discussion with our oncologist after, they also concerned about like pseudoprogression actually particularly for the immunotherapy. But what they said was that in real world, in the clinical situation, compared to the reports that there are like 10 or like more percent of pseudoprogression, but there seems to be not that much. Like she said, she hadn't seen like any of case that was like really a pseudo progression. Like it can be in the status of like SD status, but stable disease status. But like if there is a particular increase of size, like more than 30% or metabolism higher than what we have a PD, like progression of disease, then they say it seems to be a real progression, but they say there hasn't been that much case of pseudo progression in the real actual clinical field.
Right, and it is very difficult to mention possibility of pseudo progression in our viewpoint, because if there is a increase in size and increase in uptake, who can mention there is no progression? So it is a very difficult, not difficult, but it is a difficult or simple issue. So if there are no other questions or comments.
Dr. Su, I have one question.
For me?
Sorry. Thank you, Dr. Lee, for your very nice lecture. I have a question. If we have patients with clearly progressive with new lesions or higher uptake lesions, can we say just in our conclusion, can we just say new lesion or higher uptake lesion instead of progressive disease, and let the doctor explain to the patient? Because sometimes the doctor doesn't like if we write clearly progressive disease.
I can follow the question well. So
I mean, if we have for the follow-up PET-CT, we have new lesions or lesion with higher uptake than the previous scan. So in the conclusion, can we just say new lesion or higher uptake lesions, higher metabolism activity, rather than a progressive disease?
It is thank you for your question. I understand your question. I think it is according to the case by case, but as I mentioned earlier, in Korea it is a little bit unrecommended to describe clearly about progression. So I and my colleagues tend to mention just new hypermetabolic lesions or increase in size or uptake, but I still want to describe progression and aggravation. But in actual environment and government prohibit me to write that clear message. So, but I'm not sure about the circumstance of your country or your institute, but in aspect of nuclear medicine physician, I want to describe the clear diagnosis and the therapeutic implication.
Okay. Okay. Thank you very much. Thank you.
And
so if there be other questions or comments, or if not, I think we can wrap up today's session now, and then we can meet next week. Or okay, and then again, thank you very much for a wonderful lecture, Dr. Hyunjung Lee, and I think we hope to meet you again from this TEIN project. Okay, thank you very much.
네, thank you.
Thank you very much.
감사합니다.